Yes.
All right, so today we're going to talk about this peri-implant tissue reconstruction and replacement of an aesthetically failing dental implant. This was truly a multidisciplinary case. Myself, Dr. Progebin, Periodontium, as well as Jill Bailey, who's not here. She was the orthodontist on this case. So let's get into this patient and let's give you some history. Patient came to us, implants number 7 and 10 that were placed about 10 years ago. A number 10 site gradually developed some recession over the years.
Right.
She came, her chief complaint was just poor aesthetics. She was very aware and conscious about the aesthetic issue with the recession. This is the x-ray that she had initially. Implant, restoration, abutment. This was placed in Europe, so the type of the implant, I'm not really sure, but a different brand and brand name.
You can see the over-contoured restoration, which we'll see in a sec, and that's actually food impaction along the gingival margin, which contributes to the gingival recession. But for her, her major chief complaint was, I don't like my smile. And that's pretty much her smile. That's not a high smile, that's not exaggerated.
It's a very natural smile.
That is a natural smile, and obviously the restoration is in her aesthetic zone.
So full mouth series, nothing remarkable.
Pretty uneventful, healthy person, good periodontium, nothing. Yeah. So this is the critical part, and I want you to see. we're going to end on emergence profile and contour of not only the restoration, but the shared crown and abutment, both sharing the emergence profile. And as Hamid is showing you, right there is the critical over contour. Over contour of the restoration because the implant is placed so shallow. That's critical.
And incidentally, we see that there's actually a good alveolar bone. It seems like the implant was placed very nicely within the envelope of the alveolar bone.
Very
itself.
nicely for a surgeon, but maybe not so nicely for the restorative dentist.
Right.
And that's why the two of us are sitting here as the team. You know, this obviously is an unaesthetic restoration for her. And gradually, we're getting more and more of the metal of the implant showing through. So that's not only the abutment, or that's the implant body itself. The implant was placed in Europe, and we don't know the implant, we don't know the parts, company, or anything, which is presenting a problem.
So here we are. So this is kind of how the patient comes. So what are we thinking about here? So this patient came to me. I told her, I said, look, the first thing we need to do is get a restorative plan. We knew that certainly there's some challenges in terms of soft tissue, bone, position of the implant. But really the first thing all starts with a restorative plan. So what was the conversation that you had?
So for obviously the question is, can we keep the implant? What's bothering you? There were a couple of things that bother her. Not only was it that the metal collar was exposed, but that the tooth was so much narrower than the symmetrical tooth number 7. So really the width of this number 10 lateral incisor was only 5.5 maximum of the clinical crown. She didn't like that. So obviously a thought process is, would you get involved with orthodontics? Because orthodontics is going to set the site for us clinically, and it'll give us an adequate space. How much is the space that ideally I want? 6.8 millimeters, 7 millimeters. That's what I want for the width of lateral incisor. But there are a couple of surgical things to note. Surgically, this implant is placed perfectly between the buccal and palatal corridor there. Mm-hmm. But restoratively, it's not working for me, too shallow. But you can see on the CBCT, there is really good, adequate palatal bone. I mean, an abundance of good. Mm-hmm. And that will determine what our treatment options are going to be.
So really the challenge for me was how to regenerate the soft tissue and bone and replace this implant. And we'll talk about some of the treatment options that we actually entertain.
And the last thing I want you to note, obviously the CBCT is a given, but the periapical radiograph is showing us that she has good interproximal height of bone. So that's good. And I know that predictably, I'm going to get a good aesthetic result papilla-wise.
So our problem list is pretty clear. An aesthetic, poor tissue, thin tissue biotype, malpositioned tooth. This is definitely a tooth that is outside of the alignment of the arch, and maybe outside of the arch. So, because of the problems at hand, we needed a team. Obviously, with patients, it's very easy to jump into the problem at hand and saying, okay, we're going to address this implant, we're going to address this crown, we're going to make you happier. Yes, we can do all kinds of things. But to really kind of step back and sort of offer, this is an opportunity to really provide a patient with something more while they're undergoing this long treatment. And I think orthodontics is really kind of an interesting concept, which I wanted to...
But it's pretty amazing when you have to redo a failing or failed situation. It's pretty easy. You say to the person, now that they've done it that way, we have another way of doing it, maybe the right way of doing it. And 9 times out of 10, people are like, hey, look, I just want to do it right this time, because this is our second round. And orthodontics was easy. She saw that, by the way, I have overlap on my central incisor, we have crowding, my lower anterior teeth are crowded, you'll see. There are issues, my bite isn't quite right. I can address all those things, and oh, by the way, I need space for an adequate sized tooth and implant. And she's like, look, let's go for it.
Yeah, she was right on.